Assalamu alaikum. I'm Dr. Asif Nawaz, as usual, a surgical resident and the lecturer in anatomy. Today I'm going to make an important topic, that is rectum and anal canal. So let's start. As we see in the colon class, I have already told you about the difference between rectum, so colon, and along with the rectum. So rectum and the anal canal is the last part of the intestine. Rectum and anal canal is also the part of large intestine. So this is the last part. So rectum, that is after sigmoid colon. When the sigmoid colon complete, this is the sigmoid colon. See here some circular mucous fold or circulation present, but when the recto-sigmoid junction, this is the recto-sigmoid junction, sigmoid colon ends and the rectum starts from this point of view. So from this point, the inner circular mucus is absent, totally clean. So this is one of the important characteristic feature, that rectum has no power of absorption and secretion. It just storage or help in store of the fecal matters. So it is about 12 centimeter long, about 12 centimeter long, and you can see it is not look like a straight tube, because rectum means a straight tube, but here in the middle of the section you can see there are some inner folded area, like it's a shelf. It look like a shelf. It is a shelf. So these are called the valve. This is called the Huston valve. So interior of the rectum, in the interior of the rectum there are 3 or 4 valves. There are 3 or 4 valves. So these are called the permanent valve of the rectum. So what are the function of these valves? These valves will make support of the fecal matters, so that a lot of fecal matter must not come to the lower part, so that it will rise the pressure, and also it will make some discomfort to the person. That's why these valves are very necessary to hold out, to give support to the fecal matters, so that a large quantity of fecal matters can be stored. And in case of upright positions, when we stand out for a long time, but when we go out for a job or after all, a frequent urge of defecation is prevented by these valves. So these are called Huston valves. So it has also from inner to outward mucus, submucous, muscular, and the serous layer as histological features. And it has, in the muscular part, you can see there are 2 muscles. You can see there are 2 muscle layers, that is inner circular and outer longitudinal. This is the longitudinal muscle in outerly present, and this is the inner circular muscles present in the middle part of the rectal wall. So these 2 muscles has important functions. When it becomes an anal canal, goes in the lower part, these 2 muscles become changed. One will make a internal sphincter, and one will make a communication with external sphincter along with the skin, and internal longitudinal muscle will give contact with the external sphincter. Intersphincteric groove, these two area is very important for intersphincteric groove. So this is the peritoneal reflection. Here it is the rectum. Okay, it is a cross section which has the variation of male and female, because this is the male structures and this is the female peritoneal relationship. You can see there is a huge fold, it is a layer of peritoneum which is go inferiorly, and there is a gap, and now it will continuous just anterior to the rectum. So as this is the rectum is mostly peritoneum, because its peritoneum has important relationship and their extension. Anteriorly, peritoneum is present up to the anterior 2/3 of the rectum. If you imagine this is a full rectum, so anteriorly up to 2/3, in like this is the imaginary plane, so up to 2/3 rectum is present anteriorly. But in case of right side and left side, the peritoneum is present only in upper third of the rectum. Where it is present, you can see here, this is left side, this is right side, so it only present in upper 1/3. Okay, the peritoneum is reflected right and left in upper 1/3 of the rectum, but in case of anterior relation, it is only present in up to 2/3 of the anterior surface of the rectum, and posteriorly it is fully non-peritoneal. You see, this is fully non-peritoneal. Peritoneal present is almost anteriorly, but posteriorly almost non-peritoneal. But in the lower space there is a rectal fascia, posterior rectal fascia. It is also called the fascia of Waldears. It is also fascia of Waldears, that present in between sacrum and the rectum. This is the Waldears fascia. Here there is a imaginary fascia that will make a fold or space, that is called the fascia of Waldears, because in this fascia there are a lot of lymph nodes, and here is an important mesentery also present. This is called mesorectum. Okay, so mesorectum present in this fascia and a lot of lymph nodes. So any malignancy that occurs in the rectum and part of the arenchyma, so these malignancy will spread first in the mesorectum and their lymph nodes. That's why surgeon has to excise the mesorectum along with the lymph nodes. It is called total mesorectal excision. That's sometimes done along with the resection anastomosis operations. And in case of anteriorly, there is also a pouch or also a gap or fold. It is also called the recto vesicle pouch. Why it is so called? This is called the vesicle or the bladder, where the urine is hold out or stored. So it is rectum and this is bladder. Bladder is also called the vesicles. Bladder is also called the vesicles. So recto vesicle fold, that means this fold present in between rectum and the bladder. That is called the recto vesicle pouch or fold. It is also called, and this fascia is called the fascia of Denonvillers. You see, this is the fascia of Denonvillers. Denonvillers fascia just goes downwards. This is the Denonvillers fascia. Rectovesical fascia here. This is called the fascia of Denonvillers. It will form from the pouch up to the perineal body inferiorly. So this full fascia is called the Denonvillers fascia, and posteriorly it is called the Wildayer's fascia. Now in case of females, you can see there is an additional organs. It is called the uterus, the female genital organ, and the vagina. So it is the anterior area, and this is the posterior area. So this is the peritoneal reflection. Okay, this is the greenish layers. It is called the peritoneal reflection. Okay, which is reflected anterior and laterally of the rectum, and it will go outside the uterus and become continuous as a peritoneal cavity. So this is all the peritoneal cavity, and this is the peritoneal reflection. So in between rectum and uterus there is a fold. It is called the recto-uterine pouch, recto-uterine pouch, or the pouch of Douglas. It is also called the pouch of Douglas. It is also called the cul-de-sac. It is cul-de-sac, it is pouch of Douglas, and it is also called the recto-uterine pouch. Okay, and it is a bladder. So this fold is called the Basico-uterine fold. That means this is the vesicles and the uterus. So this fold is called Vesico-uterine fold. Okay, so that is the major difference in case of male and female. Now the rest of the portions. Okay, you can see here some other structures like rectum. It has 1 or 4 folds that we all know. It is also called the Hustron valve, and so their extension or situation is sometimes measured but as individualized, because its length or extension, distension can be changed from the anal canal. So this is the anal canal. So from the anal canal, third valve is about fourth valve. So fourth valve is about 2.5 centimeter from the anal canal, and third valve is 2.5 centimeter above from the fourth valve. First and second valve is about 12 centimeter from the anal canal. So this extension can be changed. It's not so important, but sometimes asked in the exam. So third valve, especially third valve, is also called the Nilaton valves. It is also called the Nilaton valves. So these valves must not be injured or destroyed, so that sometimes rectum and anal canal must be examined by the doctors. So in that case, the patient must be kept in the left lateral positions, not right, not upright, not lithotomy position. It must be in the left lateral positions, because in case of left lateral position, third valve become horizontal. Okay, so that any instrumentation or proctoscope or any camera that may not destroy the third valve. So third valve has also some developmental importance. Third valve will divide the rectum in upper chamber and lower chamber. So as it is an imaginary plane, we can divide the rectum into 2 chambers. This is the upper chamber, this is the lower chamber. So upper chamber is developed from the pre-allantoic part of hindgut. So sometimes upper chamber is developed from, must be sometimes the development of upper chamber can be asked in the exam, which is called the pre-allantoic part of hindgut, and after the lower part of the chamber of the rectum is developed from post-allantoic part of cloaca. So this is developed from pre-allantoic part, and the lower chamber is developed from post-allantoic part of cloaca. Okay, so here's some developmental importance. Somehow it is also has importance of demarcation of artery, vein and lymphatic drainage. Okay, in pararectally you can also saw some space, or this is a fat. Okay, this is called pararectal fat. Para means a side and fat means the lipid substance which will block the area or give a support to the rectum. That is called pararectal fat. So pararectal fat containing a ligament, it is called lateral ligament of rectum. This is called LLR, lateral ligament of rectum. Lateral ligament of rectum will contain the middle rectal artery and vein. So middle rectal artery and vessels, artery and vein, both are containing the lateral ligament of rectum. And you can see there is a area that is chocolate colored, that is called internal anal sphincter. This is not only, this is the circular muscle layer. Okay, this is the circular muscle layer that will makes the internal anal sphincter. Afterwards, when the rectum completed, these circular muscles will continue as the internal anal sphincter. And the outer levator ani muscles, because levator ani, here you can see these ani muscles has important 3 division. It will divide into 3 part. One is deep part, and middle one is superficial part, and the superior one is called the subcutaneous part. So these levator ani will make the external sphincter along with the longitudinal muscle of rectum. So this is the circular muscle, and in outerly there is also the longitudinal muscle. This longitudinal muscle and the levator ani muscles together form external anal sphincter. That will be discussed in the anal canal part. Okay, so why rectum is bulged anteriorly? It is one of the important question. Why this portion of the rectum is bulged anteriorly? Because it is not bulged because it is being bulged by the a fold of muscles. You can see a fold of muscle will make sling of the rectum. It is called the puborectal sling of levator ani. So levator ani muscle will sling a part of levator ani, or the muscles of perineum will hold the rectum anteriorly to make a shape so that stool can be stored. It is one of the important reason why the stool is not come frequently through the anal canal. It will make some time or storage initially. It will also gives support to the valves also. It will act as a valve. So this is called the puborectal sling of levator ani. Okay, so that now the artery supply. There are 3 artery that will give supply to the rectum. One is superior rectal artery, internal iliac artery and internal pudendal artery. This is the main source. Okay, so superior rectal artery which is a direct continuation of the inferior mesenteric artery. So superior rectal artery, which is an inferior mesenteric artery, and internal iliac artery, which is supplied through the middle rectal artery, because middle rectal artery will give supply from the internal iliac artery, and the internal pudendal artery, it will give supply to the lower part of the rectum along with the anal canal, which is give supply by the inferior rectal artery. So superior rectal artery, which is a direct branch of inferior mesenteric artery, middle rectal artery, which will give supply from the internal iliac artery, and the inferior rectal artery, which is give supply from the internal pudendal artery. Like now the venous drainage. Here, like correspondingly, there are some similarity with artery supply. Here the superior rectal vein, which is a venous, also a branch of inferior mesenteric vein. So superior rectal vein will drain to the inferior mesenteric vein. This has also some branches, like superior rectal vein has 3 branches. It goes posterior to the rectum and gives supply one branch to the left side, that is left lateral branch. One branch is go through right lateral branch, and one branch is for anterior branch. So right sided branches will divide into 2. One is anterior, one is right lateral, but left sided branch gives single supply, that is left lateral branch. It has some surgical importance because these 3 branch will make the hemorrhoidal cushion, internal hemorrhoidal plexus. These 3 branches will make internal hemorrhoidal plexus. So that's why this knowledge is very important. And the middle rectal vein, which will drain to the internal iliac vein, and the external anal sphincters. You can see some venous drainage present along with some external anal sphincter. These are the external venous plexus. They are subcutaneous, so it can be seen from exterior. If this external venous plexus becomes engorged or dilated, this can be seen from outside. So these external venous plexus will give drainage to the inferior rectal vein to the pudendal vein. So this is the internal pudendal vein. So external venous plexus will drain through the inferior rectal vein into the internal pudendal vein. So now the systemic and portal, there is a different venous drainage, because superior rectal vein will gives venous drainage to the portal vein, but middle rectal vein and inferior rectal vein, those 2 vein will ultimately drain in the internal iliac vein. This is the systemic vein and this is the portal vein. So we must not amalgamate these 2 venous drainage, because the branches of superior rectal vein along with the superior rectal vein, those all go through the portal vein. That means inferior rectal vein and the inferior rectal vein will go drain to the splenic vein ultimately as a portal vein, but internal iliac vein will go through the inferior vena cava. So that's why these 2 venous drainage must not be amalgamated. Okay. Now the lymphatic drainage. Lymphatic drainage is very important for surgical importance. So it is the bifurcation of the right and left iliac artery. So this is the rectum. First, the rectum divided into three structures: upper third, middle third, lower third. Okay. So upper third, the venous drainage of the the lymphatic drainage of the upper third will ultimately drain to the left common iliac nodes. Okay, not right, this is left. So upper third of the rectum will drain to the left common iliac nodes, and middle third, that means middle third and lower third. Okay, sorry, the middle third. So all the middle third, that is middle one third and lower one third, which will drain to the right and left internal iliac nodes. So this is the internal iliac nodes. So middle and lower third will give rise to the internal iliac nodes. And the anal canal, so the anal canal, or the part of the lower third and anal canal, which is drained through the superficial inguinal nodes. So that is the lymphatic drainage. So anal canal must be drained to the superficial inguinal nodes, but the most of the portion of the rectum will drain ultimately in the iliac nodes. This sometimes asked in the MCQ in the post graduation exam. So here it is what I said in the superior rectal vein, that is these two are the right branches, this is the left branches. So left lateral branches will form the 3 o'clock position, and the right anterior branch is form the 11 o'clock positions, and the right posterior part is called the 7 o'clock position. Because it has a surgical importance, because the piles and hemorrhoid is nothing but in these three positions. Their ingots dilated and become obstructed the anal canal by the engorgement of in these three venous plexus. So these are all the internal venous plexus or internal hemorrhoid. So they are been discussed in the surgery later on, but in the anatomy you must know the what is 11 o'clock, 7 o'clock and 3 o'clock. This is nothing but the rectal venous plexus, that is superior rectal venous plexus. In the 11 o'clock, this is right anterior venous plexus. 7 o'clock, this is right posterior venous plexus, and the left lateral venous plexus is 3 o'clock position. Okay, so there are many clinical anatomies. Later I will make a video about the clinical anatomy of the rectum anal canal. Now the anal canal. When the rectum is completed and the anal canal started, anal canal is very short. Okay, it is only 3.8 centimeter. So there are various important knowledge regarding the anal canal. You can see this is 3.8 centimeter long, and it has important two line, that is one is this line and one is this line. So when the rectum's finished and the anal canal started, so in between this layer it is called the dentate layer or dentate line or the pectinate line. Because it is a pectinate line, it is the dentate line, but this is the intermediate area, and for most lastly it is called the Hilton's white line, because it is white in color, white Hilton's white line. So there is a scientist or anatomist, Dr. Hilton, he would described this is as a developmental difference. which is called Hilton's white line. So upper part, intermediate part, and the lower part of the anal canal. So this anal canal has some interior feature and some other features, exterior features. So here you can see some blue structure. These are called the internal hemorrhoidal piles or cushion. This is also called the venous plexus, internal rectal venous plexus. Okay, there are some characteristics of the anal canal. You can see there are some multiple fold which is dented in manners. These are called the anal papilla. This folded portion is called the anal papilla, and the long folded portion is called the anal column. So these are the anal column, and the top of the anal column is called the anal papilla. And in between these two anal canal, these are called the anal sinuses. So these are the anal sinuses. The anal sinuses containing some glands which will gives secretion or like mucus, like other tubulo-lobular secretion. So this will make the anal canal slippery and mucus rich, so that the fecal matters can be easily excreted by not harming the wall. So sometimes that renal sinuses containing some glands which will become inflamed or infected, and in further that infection will lead to anal fissure, pain, abscess, and then fistula. So this kind of diseases can be occurs in the anal sinuses. And along with this line, all structures, all the anal valves, sinus, papilla, those are reunited to make a valve. It is called the anal valve. So totally this is called the anal valve. So this anal valve will be controlled by the internal anal sphincters. You can see the circular muscles of rectum that will comes directly downwards and make this sphincter powerful. So this is the internal anal sphincter. It will act upon the anal valve and which will prevent the flutters and the fluid. So the fluid comes from the rectum and the gas that will prevented by internal anal sphincter, which is involuntary. And the externally you can see a thick muscle which is called the levator ani muscle, and the part of the longitudinal muscles of the rectum. These two muscles will voluntarily stop or prevent the fecal matters to go outside. This is the nervous activity, because internal anal sphincter will be supplied by the autonomic nervous system like sympathetic and parasympathetic, but the external sphincter will supplied by pudendal nerve, which is somatic supply, which is voluntary. So if we want to hold the defecation, it will be controlled by the external anal sphincter, but fluid and gases will be controlled by internal anal sphincter. And now the intermediate area. The intermediate area of the anal canal has devoid of sebaceous gland, sweat gland, and the hair follicles, because in this layer there is nothing present, no gland, no hair follicles. But now the Hilton's white line, this is called the Hilton's white line, and after the Hilton's white line it is mostly cutaneous, because skin will become indurated and will rely on the Hilton's white line. So before the Hilton's white line, these structures are painless due to the autonomic nervous system. But after the Hilton's white line, these area will be supplied by the somatic nervous system, that is pudendal nerve. So in case of surgery, sometimes Hilton's white line along the intermediate area will be saved by a guard, so that the patient will not suffer from a chronic pain, a lot of pain from his rest of the life, because any injury that occurs in this area will make tremendous pain or tremendous discomfort that will suffer that patient in whole life. Okay, now there is another important structure I forgot, that is a conjoint or the longitudinal ligament muscle layer that will make a branch. You can see there are some branches, that is called the corrugator cutis ani. So longitudinal muscles will further make an external sphincter and corrugator cutis ani, which will extend up to the skin. Here you can see there are branches, which is continuation of the conjoint longitudinal muscles. And the transverse, that is external anal sphincter, is also branched sometimes. Here is the branch, here is the branch. So these branches is formed by fibrous, transverse, fibrous, septum. You can see this is called transverse, fibrous, septum. It will give extra support to the external anal sphincter to make a good contraction. There is no other importance, but sometimes it will help to make a good contraction, so that the grip of the external sphincter becomes strong due to presence of corrugator cutis ani and the transverse fibrous septum. And as far as I already described, that artery supply is pudendal artery, and venous drainage is pudendal vein, and the lymphatic drainage is superficial inguinal lymph node. And the nervous system is before Hilton's white line. It is sympathetic and parasympathetic supply. Sympathetic is hypogastric nerve plexus, as always, lumbar first and second, and the parasympathetic supply is sacral second, third and fourth, or the nervi regentis. And below the Hilton's white line, this is called internal pudendal nerve. So internal pudendal nerve will give somatic supply to the sphincter, and also the lower part of sacral fourth. Sometimes pudendal nerve along with the lower part of the sacral fourth. These two nerves will make somatic supply perfectly. So that is all about our today's lecture. Thanks for watching.